Okay, Dr. Deuk Majan here with a team at Deuk Spine, and we're getting ready to start our Deuk laser disc repair on a patient who's had back pain radiating down the left leg. He has two herniated discs, L4-S1 and L4-5. So we're going to get started. You're doing great. Everything's okay. Just lay still. You're fine. Lay still. Don't move. All right. So we're going to give a little more numbing medicine. I don't know that that's going to fix the problem. I think I need Dr. Berndes' help. All right, so our goal here is to get down to the L5-S1 and then, of course, the L4-5. And I've numbed him up pretty good. I want to start a little bit lower. Shot. We're going to use our X-ray machine to guide the surgery. You could see the L5-S1 disc there at the bottom. Shot. That's the first one we're aiming for. Lay still. You're doing great. Everything's okay. So that's the facet joint shot. Now the path we take is called transforaminal. We're going through a hole that's already present, basically in the side of the spine. Shot. Lay still, you're doing great. A little num-num. For those of you who watch our surgeries, you know the patient needs to be awake for the lumbar cases in the beginning. Let's keep an eye on the blood pressure and try to keep it optimal. Shot. All right. We're aiming for the L5-S1 disc. Can you all see that? I know you can. Can our audience see it? Shot. Shot. All right, we're making some progress. Not quite there yet, but we're getting close. Shot. Now, if you find yourself too medial as a surgeon, too close to the midline, you can always restart a little bit more laterally, and that's what I like to do. All right, that's too superior. Shot. That's more like it right there. Shot. Let's get an AP. So we're aiming for L5-S1, the bottom disc. The reason I started L5-S1 is the hardest to get to, so sometimes you have to change your entry point. And that's why you always want to go to L5-S1 first. Go ahead, lateral. Okay. I'll show you what I'm talking about. Is he reliable yet? Wait a little while.
You all right? Can you open your eyes for me?
Hey, can you see if we can wag that a little better? I mean, it's pretty darn good where it is. Just see if that improves it. Shot. That's better. Wouldn't you agree? To me, that looks better. That looks actually really good. Yeah. So we're in pretty good position. Shot. I want to come in low. That looks really good right there. You comfy?
You having any discomfort? My friend, can you open your eyes? Good. Having any pain? Down your leg or anything?
I can wait just a minute. Not a problem. All right. I'm very happy with this. I'm going to pull back just a little bit, and then I could redirect it. I want to go just a little bit south. The souther the better. You really want to come in at the bottom of the foramen. Shot? You want to come in at the bottom. and you want to be underneath the exiting nerve root. So we're going to make our incision. This will be 7 millimeters. Again, the narrowest spine incision, or the smallest incision you can make. Now, all of our patients are off of their blood thinners or any kind of medicine that would cause them to bleed a little bit. But some people take herbal medication, and that can make them ooze. And I think this patient is taking something herbally. If I had to guess, I'd say turmeric, because that's a very common herbal medication that is believed to improve health. Just lay still. That blood pressure hasn't changed in a while. Where is he at? Is that our latest x-ray? Yeah. So, shot. I'm up against the facet. I want to be a little bit more superior up towards the head. Shot. That's perfect. A little bit more superior. Shot. Anybody see Friday the 13th? If you missed it, we got it going on right here. How's his blood pressure? I'm just going to hold pressure. So clearly this patient may not be on a non-steroidal, but they're taking something that is anti-inflammatory. Shot. All right. And also, most anti-inflammatories are going to cause patients to bleed. There we go. AP. So I'm just putting, we could try, sure. You have some more, is there epinephrine in there?
Yes, sir.
Yeah, let me have it. Hold on, Jordan.
Yes, sir.
Jeez. Are the nurses asking in pre-op about?
He's only had one medicine, that's it.
No what?
No vitamins, nothing over the counter.
Yeah. Well, there's 100% chance that he's on something that is causing thinning. That I have no doubt about. Yeah, let's keep it down. Because look at that's already helping.
Can I
Shot.
a little bit more, please? I'm sorry.
All right, good. Back to a lateral.
Keep your head still, sir. You're moving your head. Can you
Don't move.
please? It's a narrow bed.
Is he awake? I need him awake.
How are you? You okay?
Just let me know when he's awake. I think the worst disc is 4-5, right? Shot? Luis?
The worst one?
Yeah, shot. Don't move.
Are you having any pain, sir? Oh, can you open your eyes?
Shot.
Can you open your eyes? Any pain?
Shot. Shot. Don't move.
No?
Just lay still.
Okay, lay still.
Lay still. Don't move. All right. Lay still. You're doing fine.
Put your head down.
Let's let him wake up a little bit so we can
Sure.
get an accurate determination. Lay still.
Can you open your eyes?
So some people are a little bit confused when they have anesthesia and they're waking up. Can you hear me? Can you hear me? How's he doing? Is he waking up?
There you go. Hello? Can you open your eyes? Can you open your eyes? Not yet?
All right, so at this point, we're just waiting for him to be more awake. He's had some anesthesia.
Sarah, can we switch?
As he's waking up, he's moving around a lot.
Thank you.
Everybody wakes up differently. Lay still. Most people aren't used to waking up being on an operating table.
Stop moving. You're on a narrow table.
All right, he has 2 disc herniations, L4-5, L5-S1, that are in the area of his pain. And when I saw him, I asked him, where is your pain? And he said, it's right in this area here. So I looked at the MRI, and there was 2 herniated discs, L4-5, L5-S1. He also has a small annular tear and a herniation that's very tiny up higher at L3-4. I asked him, do you have pain up here? He said no. So that's why we're fixing the bottom 2 discs, because they're the worst. We need you to lay still.
Okay? Keep your head down. We're going to ask you some questions.
Don't move around so much.
All right?
Lay still.
Stop moving.
Jordan, get in there and help out, please. Control the wrist and don't let him put his wrist down. And he got propofol, right? No benzo? Huh?
Hey, can you open your eyes for me?
Oscar, go help out.
Open your eyes for me.
Don't try to get up. We need you laying down.
Open your eyes for me.
All right, we're just letting him wake up a little more. Oscar, take a look at me. The only way patients can move is if they put the weight on their elbow, right? So what you do is you take their arm and pull it north. That way they can't put their weight on their elbow. They're in the surrender position. All right? So do that for both sides, and then he won't be able to lift his torso up, which is what we want. We don't want him lifting his torso up. Hey, it's Dr. Deuk. Just lay still here. We're waking you up so we can ask you some questions. What's the issue, guys?
It's just dysphoric. Propofol. Everything else is a little different.
So he only got the propofol, right?
Stay still. Stay still. Stay still.
Is he awake? All right, as soon as we get him awake, we can do our discogram and put him back to sleep. What is it? What is Jordan doing? All right. Can you hear me? Can you hear me? Are you awake? Can you hear me?
Hey, my friend. Can you hear me?
Can you open your eyes?
Yeah?
Is he responding appropriately?
Can you
All
open
right.
your eyes?
Tell him that he needs to stop moving and trying to get off the table.
You need
Okay?
to stop moving, okay? You're on a narrow bed. You gotta stay still.
Have him open his eyes for you.
Can you hear me?
He's getting a good sleep. We were waking him up. He's not happy about that. Jordan, is the arm board fixed?
Good?
Can you hear me?
You okay?
You're supposed to be looking for some reason. So careful.
Well, he probably leaving because his favorite carry with him, yeah.
If that happens, the best thing to do is to put the arm board out to the side, straight out,
The only way I got it, I
and then get it in.
pulled out enough.
Hey, my friend.
Thank you.
How are you doing?
Can you hear me? Can you hear me?
Okay, we're well waiting for you to stop moving, all right? You got to stop moving your body. Can you hear me? Are you having any pain? Are you having any pain?
You having pain?
Can you open your eyes for me? Can you open? Can you open? Good. Open your eyes. Big now, big and wide. Open your eyes. Are you having any pain in your back? Yes or no?
He's almost there. All right, so we're just sitting here waiting for him to wake up a little bit more because we need his cooperation and help. And we need his conscious brain working. You didn't give him that much propofol, right? Yeah. So here's a patient who doesn't, obviously, probably doesn't take many drugs at all, no medicines.
Takes blood pressure medicines only.
And so when you give the patient like that a little bit of sedative, which is the propofol, it really has a profound effect.
Not in there.
So not everybody. Long story short, we're just waiting for the sleeping medicine that we gave him to wear off. And you could see as he was coming out of it, he was moving around quite a bit. That's all unconscious movements. Let me know when we're ready to ask him questions. Are you comfy?
Having any pain? No. No pain?
All right, we need you to lay still, okay? Can you hear me? All right. All right. How bad is that pain right there on a scale of 1 to 10? How bad? On a scale of 1 to 10? 10? Is that where you get your back pain? Is that where you get your back pain?
Is that where you get your pain?
Okay, good. We tested one of the discs. Is that better now?
Is it better now?
Wait.
Yes, it's better.
How bad is that on a scale of 1 to 10? 10? Is that where you get your pain?
Is that where you get your pain?
All right, so now we're going to put him to sleep because we've done our discogram. We've safely navigated to the 2 discs, and we're ready for him to actually go to sleep and stay asleep for the rest of the surgery. So our anesthesiologist is going to put him to sleep, but not too much asleep. Okay, any questions from the audience?
Yes, we have a question from Canes25 on YouTube.
All right, happy to take the question.
And they ask, Doc, what's hemanoma, hemanoma, and how can it affect the spine in any way? Thank you.
Yeah, so first of all, thanks for asking a question. I'm not sure what you're asking. I think you've maybe misspelled it or Henry has mispronounced it, but
I believe I'm mispronouncing it.
It may be a hemangioma.
Correct. Yep.
Hemangioma.
Correct.
So a hemangioma is like a blood vessel inside the bone, and they're very common, and they don't do anything. We leave them alone. They never cause problems. Okay, lay still.
Hold nice and still during surgery. There is a little table.
Shot. Patient's what? Yeah, take your time. We're not doing anything. We've just given him a little bit of numbing medicine in the disc, as well as a discogram. And we're going to take your time with him. You let me know when you're ready, doctor. Talking to my anesthesiologist. So hemangioma is just a, it's just a basically cystic venous channel. And it's a vein inside the bone, within the diploic bone. And they're very common, and we don't do anything about them. They're totally normal. Pull the guide wire back a little bit if you haven't already. Shot?
Yeah.
Not too far back, yeah. I wouldn't go any further back than that. All right.
More?
Nope. Can't pull it all the way out, otherwise we'll have a problem.
Yeah.
All right. Great question. Thanks for asking. Just forget about the hemangioma. It's nothing, not doing anything. Everyone has them. Shot?
A little local in there?
Already did. He's got a huge tear at 5'1". I feel this thing just going in. take the guide wire out. You're fine. You're fine. You're doing great. Guys, I think you need to get in and make sure you have some arm support. Just keep the wrist up north towards anesthesia, and he should be fine. Looks good. Shot. That's going to be the most stimulating part for now. So, good. Let's get the fluoro out. Thanks, guys. Any other questions, Henry?
No current questions.
All right, let's go ahead and show the video on how does a herniated disc actually cause back pain. And take a look at this video animation. It explains it. And then we'll come back and see some more surgery.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back, and you've had an opportunity now to see how does a herniated disc, bulging disc, how do they cause so much pain? And the answer is inflammation in just the right spot. Inflammation is basically your body trying to heal a problem, fix a problem. So your inflammatory system is made up of cells. Can we move that light over a little? It's blocking my view. It's made up of specialized cells and molecules, biochemical molecules that basically are designed to fight off any foreign invaders to your body. It's a very old system. It's been around for a long time. And it has cells like macrophage, polymorphonucleocyte, fibroblasts, and endothelial cells, stem cells. They're all involved in the process of inflammation. So are blood vessels and mediators called cytokines, inflammatory mediators. These cytokines have lots of names, like tumor necrosis factor, epithelial growth factor, and a variety of others. I don't have the names of all of them. But basically, they are chemical signals in your body of different tissues. See that? Signaling to each other to bring in the inflammatory cells and attack. Now, what are they attacking? They're attacking the herniation. So, they're attacking the herniation and causing more inflammation and ultimately scar tissue and damage. So a degenerative disc disease is actually the end result of years of chronic inflammation going on inside your disc from a herniation, causing it. We're the first persons to discover that here at Deuk Spine Institute through the years and years of research and studying this disease. We've discovered that all of the degenerative disc disease starts out as a herniated disc, an annular tear, a disc herniation, and then that creates inflammation within the annulus from the blood vessels just outside the annulus and within the outer half of the wall of the annulus. And that inflammation spreads throughout your whole disc, causing the entire disc to degenerate over time. Now, the scientist who studied this the most was a scientist named Rausching, who was a Swedish, I think he was a Swedish neuroanatomist, and he used to take patients who had chronic back pain in the villages, and he would go to the morgue after they died, and he would ask to slice their spines open and look at their discs. And he found that the discs had all this inflammatory tissue in them. And he took these slides of those discs and he tried presenting it to people and showing them that there was some type of an inflammation going on inside the disc. That's what I learned, 20 years ago, 30 years ago. And I applied that knowledge to my practice where I'm treating patients with back pain and discovered that he was right. There's all this inflammatory tissue right here. This is what he was seeing. All this stuff that I'm zapping away with the laser is that inflammatory tissue. And when you get rid of it, you get rid of the back pain. Or if it's in the neck, you get rid of neck pain. It's really the same condition, whether it's in the back or the neck or the thoracic spine. It is the source of the pain. Unfortunately, most doctors don't know that. I'm almost done with this disc, but we are definitely in the outer parts, so he's going to be feeling something soon. Huh? Take your time. I'll wait. No problem. Any questions?
Yes, we have a question from Trish on Facebook.
All
and,
right.
and Trish asked, I'm sorry I am joining late. What is this patient's diagnosis and what are their disc herniations?
Hi, Trish. Welcome. See this blue thing right here, Trish? That is a herniated disc. That is the nucleus pulposus. And that stuff is normally in the middle of the disc, but it's squeezed out through a tear in the wall of the disc called an annular tear. The patient's diagnosis is back pain, chronic back pain, pain down his leg on the left side, which we call sciatica, and basically weakness in the leg because of the nerve being pinched, the nerve root being pinched. We call that radiculopathy. And stenosis because of the narrowing happening here in the foramen, so foraminal stenosis, spinal stenosis, and an annular tear, and like I said, disc herniation. So all of those things interrelated, causing back pain and leg symptoms. And he's tired of his back pain, tired of his leg pain, wanted it fixed. So he came to Deuk Spine and we're doing an endoscopic surgery. This is the only place right now in the United States doing this particular surgery where we clean the tear and the herniation out using a laser. Now we're also cleaning out the inflammatory tissue, which is causing all of his back pain. The inflammatory tissue is here because his body is attacking the herniation, trying to get rid of it. It's kind of like your body attacking a splinter in your finger or under your skin, a piece of wood. If you get a piece of wood under your skin, it's going to get red and swollen and tender. That's inflammation. That's your body trying to get rid of that piece of wood under your skin by attacking it and breaking it up into little pieces. There's a piece of herniation right there.
Question from the live audience.
Sure. A little louder.
Question from the live audience.
Okay, thank you.
If someone receives a piriformis or has an injury to
I
piriformis,
can't hear you. Piriformis.
if someone has an injury to the piriformis, what locus of pain would that be?
Where is the pain when they have a piriformis injury?
Yeah.
It's in the top of the buttock, on the side of the piriformis. There's a left piriformis and a right piriformis in the butt cheek. And when you have pain in the top of your butt cheek, kind of lower back pain-ish, that could be a piriformis tear. Piriformis syndrome is inflammation within the piriformis muscle as a result of injury to the muscle from tearing it.
So what would I label that?
That would be a
Location.
piriformis syndrome.
No location.
Left or right? It's
Right.
lower back pain.
I'm talking about for our study.
Yes, it would be piriformis syndrome.
Okay. How about for SI joint?
SI joint will be sacroiliac joint.
Do I need to specify which joint it's on?
Which side?
Which side?
I don't think it's that important, but you can if you want, if it's easy to keep track of that data. But you don't really need to. It's just sacroiliac joint, piriformis. Doesn't matter if it's left or right. All right, so let's show the audience what it is we're doing with this Deuk laser disc repair surgery. What's actually happening here?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. Now you see what the Deuk laser disc repair is all about. Tiny incision, Band-Aid, and then we go in and basically remove the herniation as well as clean the tear in the annulus that it came out of. By cleaning the tear, it allows the tear to re-heal and reseal. Heal and reseal. That means the future, you're not going to have any more herniations from there. Nobody else does the laser disc repair and debridement except us here at Deuk Spine. It's the most advanced spine surgery in the world. Unfortunately, most spine surgeons don't know how to do it. Doesn't matter where they operate. Sometimes I get people saying things like, well, my spine surgeon at Johns Hopkins, or my spine surgeon at Harvard, or my spine surgeon at Columbia, and I just laugh inside to myself about those spine surgeons at Harvard, Columbia, Hopkins, or wherever they are. It doesn't matter where you practice or where you train. What matters is how good of a spine surgeon you are. And if your reputation is about, I'm a Harvard neurosurgeon or I'm a Harvard spine surgeon, and that's how people think of you, then that's not what I want for myself. What I want is I want people to say, Dr. Deuk, the surgeon who fixed my back pain. That's what matters to me. The result for the patient, not the result for me. All right, next is the L4-5. And I agree with you. If your surgeon works at Harvard or Columbia or Johns Hopkins, they should be doing the most advanced surgery in the world, but they're not. That's nothing I can do about that. All right. Did you put the dilator in the right hole?
What do
Did you
you
put it in the middle hole or the side hole?
What? In the middle hole.
No, did you put it in the middle hole here?
Yeah.
Because it look, where's the x-ray shot? Shot? No, you put in the side hole. You see? You see it?
I see. Okay.
Come on out. That's what I'm talking about. Attention to detail. Okay? People don't understand the detail that you have to pay attention to until, you know, maybe they never understand, but yeah, that's good. But Luis is my trusted right-hand man. And in life, sometimes we all have to learn through making a mistake. But then you never forget, right?
Yes, sir.
All right, so we're about to do the L4-5, and this will be the last disc. I know Dr. Berndes is breathing a sigh of relief. Right, Dr. Berndes? Okay. Because this patient is particularly challenging from an anesthesia standpoint. And I would, when we're done, I would make sure you guys get the gurney in. Try to, I don't know, flip him maybe while he's still a little sleepy. What do you think? That way. Oh yeah, the last two were amazing, right? They didn't even move. But some patients are just very sensitive. Shot? Shot? Perfect. Okay. Any questions from our audience?
Yes, we have a question from Conzi Debate on YouTube,
Uh-huh.
and they ask, would you utilize mesenchymal stem cells, MSCs, in conjunction with your laser treatment, assuming complete medical freedom were allowed in the U.S.?
Yeah.
Mesenchymal, excuse me.
Yeah, mesenchymal or mesenchymal. But the point is, I would not. And the reason why we don't use stem cells is because we've tried it before. And the thing about stem cells, folks, that you need to understand is that they cause inflammation. They cause inflammation, a lot of inflammation. So after the surgery, the patient that we tried the stem cells on had horrible back pain from inflammation. Eventually went away after 3 months. But man, she was miserable. So we don't offer stem cells anymore with the procedure because number one, it's unnecessary. And number two, it creates more pain for the patient after surgery. So I'm not really in favor of it. We do offer stem cells here at Deuk Spine, but not for this procedure. Now, if a patient told me, I'm okay with the pain after surgery, I just want stem cells, then I would do it because I don't think there's a safety concern. I think there's just a pain concern. And my patients normally don't have much pain after surgery, so I like to keep it that way. After all, that's why they get the surgery. They want to get out of pain. Yeah, he can go. I've already seen him. I'll see him tomorrow. Yeah, the last surgery wants to go home. He's doing fantastic. He can go home. Did he have blue in his pee anyway, just out of curiosity? I wonder if the amount of blue in the... I know, but maybe it's related to the number of discs we're doing. In other words, more discs, more dye, more blue pee, right? Yeah, that would be interesting to see with the nurses and the patients is... Yeah, I think if you look at the amount of dye I inject, maybe it's correlated to that. Because eventually the dye goes to the urine, you know, gets the kidney, right, gets filtered out and ends up in the pee.
That's his plexus case.
What is it?
That's his plexus.
Yeah. Sorry, Henry, was there another question?
There are no current questions, but we do have a comment from Trish, who says that they had a consult with you via Zoom and hopes to see you very soon.
Wonderful, Trish. Looking forward to it. Yeah, so in case you didn't know, Deuk Spine Institute offers a free MRI review or a virtual consultation, basically to help people get answers and figure out what's wrong. And then, of course, if they decide to come and treat here, great. They're going to get the best care in the world. On the other hand, if they don't, that's okay too. As long as they're getting information and we're helping them make decisions. All right, just about done. You can actually see this particular tear is right up against the vertebral body. You see that? That's the end plate. So this annular tear, if you look carefully, that vertebral body right there is the L5 superior end plate. The tear is right up against the end plate. And then, of course, higher up in the disc, you don't have the tear, you don't have the blue dye, but I have to go get rid of all the herniation I can. So this was a low tear in the disc. These tears can happen through the middle of the annulus, or they can happen near the top or near the bottom. And I honestly don't know what makes one happen one way versus another. Nobody knows. Nobody's ever looked at that biomechanically or studied the biomechanics of their injury. The problem is most of the patients we see, they don't even remember having trauma. And a lot of these tears happened 10, 20, 30 years ago. So when you ask patients, when did this happen? A lot of them will say, I don't know. I don't remember ever happening. Probably half the patients don't remember the incident that had occurred. A lot of reason for that is because the pain happens suddenly and then it goes away after a day or a few hours. And that's when their tear occurred, but the herniation wasn't bad then. And then it got worse over time. We need about 1 minute left maybe, or sorry, about 3 minutes left. Berndes?
We have a question from the live audience.
Yes.
What is neuroforaminal stenosis?
What is neuroforaminal stenosis? So the neuroforamen is the hole in the side of the spine there where the nerves come out. And stenosis just means narrowing. It's Latin. It means narrowing. So when we talk about stenosis in medicine, we're talking about narrowing of something. And if it's your artery, carotid artery, it's carotid artery stenosis, narrowing of the artery feeding your brain. But in the spine, spinal stenosis has different types of spinal stenosis depending on where it's located. I'm just watching Luis's eyes widen.
Can stenosis be considered a cause of lower back pain?
Yeah, will stenosis be considered a cause of lower back pain? 100% no. Stenosis only causes leg pain, never back pain. And it really doesn't even cause leg pain. It causes weakness, numbness, and tingling in the legs, or what we call neurogenic claudication. Neurogenic claudication is when the nerve roots get strangled by the stenosis, and it's worse when they're standing and walking, but gets better when people are sitting. So even though the tear started at the bottom of the disc, it's actually extending up here. You can see all the herniation further up towards the L4 vertebral body. Bit of a surprise. It's kind of a really bad tear here. I need a few more minutes. All that blue is guiding me. That's why we do the blue dye, because it shows me where the herniation is. And I know that I can't leave any of that stuff or the patient will still have a problem. So spinal stenosis never causes back pain. Ever, ever, ever. There's not a single case of spinal stenosis causing back pain. Now, people with back pain have spinal stenosis, but that's not the cause of their back pain. That's why when they get a laminectomy, they don't get better. Because the laminectomy treats spinal stenosis, but it doesn't treat back pain. It's kind of a rotten disc right here. You see that? All that blue in there? Kind of hidden away underneath the white fibers. I just can't leave that stuff. It's going to create symptoms in the patient. So I want to try to get as much of it out as I can. Any more questions from our audience? Let's grab that.
No current questions.
All right. We need about another minute or two, and we'll be done with this surgery. I want my team to be ready because he's a mover shaker. Okay? So we need to have everything ready for some movement. Dr. Berndes, you want to orchestrate? Huh? Okay. Perfect. Sounds good. Yep, we don't like poking the hibernating bear. But his surgery, he was not blue, despite 3 discs. Oh, okay, all right. Yeah, he may be a little dehydrated. Yeah, he may not be making as much pee. Yep.
We didn't inject too much neither.
Yeah, we didn't inject much. But she said last time he didn't either. And the last time we injected a lot. So it may have something to do with GFR then. Yeah, but they're normal, I mean. But he may just be dehydrated but his GFR, not in general GFR, but for the case GFR. Like he may be dry, so he's not producing as much pee. In which case the dye would slowly come out over a few days. All right, just about done. Any other questions?
No current question.
For those of you watching, Duke Spine Institute has an app on our iPhone as well as Android. You're welcome to download it. It's free. And we do have another surgery coming up later on after this one. It's a single level. So if you want to join us, it'll be our last DLDR for the day. And we got a DPR, Duke plasma rhizotomy, to treat cervical facet pain at the end. All right, let me just see here. I don't see anything more. And we're at the back of the disc at this point. I've done just about everything I can. Are you guys ready? Excellent. Last of the herniation, last of the tear right there. The nerve root's going to be up there in that fat. But that's it. We're done with this herniation. Now his disc will heal in a pain-free state, hopefully. I mean, he's already kind of oozing. I mean, if you can get away without it, that'd be better, but I don't think there's anything wrong with doing it. You just see how oozy he is naturally. Thank you. Yeah, we had no bleeding after the beginning. Yeah. All right. You sound like a chiropractor. They say spinal manipulation fixes every disease there is. Blood pressure, diabetes, ulcers. Num num fixes everything.
What num num fixes? It affects heart rate, so it decreases heart rate, decreases blood pressure, right? So it decreases afterload, decreases preload, right?
Decreases pain, so stress, adrenal cortex, cortisol. So maybe you're right. Maybe num num is the solution to all the world's problems.
What about num num when you have a
Ready?
patient that has number one CG now?
But I'm giving you the basic science factual data.
Of course, of course. All right. Any other questions?
No current questions.
All right, let's go ahead and end the broadcast. And thank you. Great job, everybody. And we'll be back shortly with our last laser of the day.